infection, LTBI, and community provider webinar and training. So in the past year, TB incidence in New York State was at its highest point in the past decade, with 894 cases reported statewide, which is a 25.2% increase from a total of 714 cases in 2022. This reflects an increasing TB rate nationwide. And while we don't know the exact reasons why TB incidence has increased, we can speculate that it's driven by a constellation of factors, including the fact that TB cases are increasing globally. And given that there's been an increase in post-COVID travel and an increase in non-US born individuals migrating to New York City and other parts of New York State, some of whom come from high incidence TB countries, it follows that there may be an increase in TB incidence across the state. Other potential causes of the increase are the often discussed lags in diagnosis and treatment of TB during the COVID pandemic, as well as ongoing COVID-related disruptions to the public health system and healthcare systems. So in the US, as we know, testing, early diagnosis, and effective treatment of latent TB coupled with extensive contact tracing are all critical to preventing active TB disease. So in 2023, our Bureau released an LTBI toolkit for primary care providers, which is on our webpage, and I think that link will be shared with you. So the purpose of this training is to provide a demonstration of how to use the toolkit. And Melanie Dolan, our Bureau's public health nurse, along with Anthony Maloney, developed the toolkit. And I will turn things over to Melanie now. Thanks.
Thank you, Delia. And thank you, everyone, for taking time out of your busy day to attend this webinar. I know you all are busy. My name is Melanie Dolan. I am the public health program nurse for the New York State Department of Health Bureau of Tuberculosis Control. And as Delia mentioned, I'm here with Anthony Maloney, and we are going to present the Latent TB Infection and Community Providers webinar. And I apologize for not having a camera. I don't have one on my computer at this time. And this webinar is being recorded. If you have any questions during the webinar, please write them in the chat. And we're very happy to announce we have our medical director, Dr. Devin Hatzengate, and he will be available after the webinar to answer these questions, answer any of your questions as they come in at that time. There will be 4 polling questions, 4 after my section of this webinar, and then 1 at the end after Anthony does his reviews the toolkit. Next slide, please. This is the overview of the webinar, very brief overview of Mycobacterium tuberculosis infection. Then I'm going to just share some tuberculosis data. Then touch base on latent tuberculosis infection and public health, just a little historical look back. And then community provider collaboration, and this is a discussion on how community providers and public health can collaborate in treating patients for latent tuberculosis infection. And then the latent tuberculosis infection, we'll review some of the treatment regimens, and then Anthony will review the latent tuberculosis infection toolkit. Next slide, please. So tuberculosis infection, we all know anyone who has pulmonary tuberculosis is infectious or can be infectious. And the TB is spread through droplets containing the tubercle bacilli. They're inhaled by another individual, and the bacilli can reach the alveoli of the lungs. Once it reaches the lungs, the alveolar macrophages ingest the tubercle bacilli, and then they can start or may start multiplying. And then they can be released into the lungs through the lymphatic system, into the bloodstream. And then the person can become symptomatic, and that becomes active TB. Okay. The alveolar macrophages if the alveolar macrophages ingest the tubercle bacilli and they get walled off, and most of them are destroyed by the person's immune system, that is latent tuberculosis. This person still has potential to become active. And I'm just kind of planting a seed here. There is a a chart that is most people are familiar with that describes latent tuberculosis versus active tuberculosis and the differences. But TB has been described by experts as being on a continuum, beginning with TB infection. And then TB infection can go through a process and then lead to TB, active TB with signs and symptoms. And there are a lot of different stages in that process. And this is where assessment, TB risk assessment, and then testing your patients can be very helpful and important. Next slide, please. So tuberculosis data, I like to kind of start large and then focus in on our area. The World Health Organization, or WHO, reports the estimated global total of 10.6 million people had TB in 2022. This is the highest number since they began global TB monitoring in 1995. TB remained the world's second leading cause of death from a single infectious agent in 2022, and that is after COVID-19. In the United States, according to the CDC, there were 9,615 active TB cases, and that was in 2023. Next slide, please. And now bring it back home to New York State. In 2023, there were 894 cases, and this is, Delia had just mentioned some of this data. There were 894 cases that were reported statewide, and a 25.2% increase from the 714 reported cases in 2022. And a statewide, the case rate was 4.4% per 100,000 population. And then in New York State, excluding New York City, so New York City is a separate reporting jurisdiction. So the rest of state had 210 cases of tuberculosis, and that was a 17.8% increase from 2022. In 2023, the case rate, excluding New York City, was 1.8 per 100,000 population. Next slide, please. And as previously mentioned, some of the contributing factors to the rise in TB cases over the last 2 years is, TB cases are increasing globally. There's been an increase in travel post-pandemic. The COVID pandemic caused delayed diagnosis and treatment. People were afraid to go to the doctor, right? And post-pandemic impacts on public health systems, on the medical system, including access to and provision of health services. We all have experienced the impact of the post-pandemic experience. Next slide, please. Public health responsibility. So this is kind of a look back for individuals who aren't really sure what the public health responsibility is in TB care. Local health departments are responsible for providing or securing tuberculosis services for active TB cases and contacts of active cases. And this includes the treatment oversight, case management, and directly observed therapy. Historically, community referrals for both active TB and latent TB were sent to local health department TB programs. Over the last few decades, more and more private providers, so those providers not affiliated with local health or public health, are treating patients for active TB, and that is done with the support and oversight of local health. In New York State, more of larger health departments have, or some have larger health departments, can provide comprehensive TB services. And that includes TB testing, clinical evaluations, LTBI treatment, and outreach services. In smaller local health departments, in areas that are less populated or rural, the local health departments they're still required to provide these services with active TB cases, but they may do so differently depending on their resources. They may contract out for active TB provider services, or latent tuberculosis services. So they may contract out for both. Some may reserve their latent tuberculosis infection clinics for those who are underinsured or uninsured. Local health departments are continuing to receive many referrals from community providers, occupational health offices, urgent care centers, and this is the general medical community. Next slide, please. So this, we all, we've talked about active TB, latent TB. We all know persons who are infected with TB bacteria, but do not have active TB, cannot transmit TB to others. They are not infectious. Latent tuberculosis infection is currently not a reportable condition in New York State. And it's estimated that there are up to 13 million people in the United States living with latent tuberculosis infection. And 5 to 10% of those individuals will develop active tuberculosis disease if untreated. Next slide, please. The Center for Disease Control and Prevention, Division of Tuberculosis Elimination, has a mission statement. And the mission statement is to promote health, quality of life by preventing, controlling, and eventually eliminating tuberculosis in the United States. Next slide, please. This is an infographic from the CDC website, and it is encouraging healthcare providers to work with public health. Public healthcare providers can take action to end TB. First step is to think about tuberculosis and recognize the risk factors and symptoms. Second step is to test those individuals for tuberculosis, and 3 is to treat for latent tuberculosis, or if you find active disease, report it to the health department. Next slide, please. The role of the medical community. In 2023, the CDC and the U.S. Preventative Services Task Force released guidelines in which they recommend testing persons at increased risk for TB infection as a part of routine health care. And as a primary care physician, you have an established patient base. You are in a perfect position to either do a risk assessment as patients are admitted to your service, or you have an established patient base. You know your patients the best. That your patients trust you, so you are in an excellent position to, if they test positive, to discuss latent TB infection treatment options with your patients. And then you are in a good position to treat your patients for latent TB infection, and you have resources, expert resources available through the local health department, through the state health department, and through regional centers of excellence. Next slide, please. Assessing for risk factors. Individuals who may be recently infected are at risk, and that includes close contacts of persons with infectious TB disease, persons who have immigrated within the last 5 years from areas with high rates of TB, persons with prolonged stay that's greater than 1 month in areas with high TB rates, and that's any country other than the United States, Canada, Australia, New Zealand, or countries in Western or Northern Europe. Persons who live or work in clinical or institutional settings where TB exposure may be likely are at risk, and then children less than 5 years of age who are exposed to adults in high-risk categories. Next slide, please. Assessing for risk factors related to clinical conditions. So some individuals are at higher risk to progress to TB disease if infected. And those persons include persons with HIV infection, persons with low body weight, evidence of old healed TB lesions on an X-ray, persons with certain medical conditions, bolded here, diabetes, because that's on the rise as a comorbid condition. Persons receiving immunosuppressive therapy, and people who inject drugs, and primarily that's related to lifestyle. Next slide, please. Comorbidities of interest are HIV, and if a person with HIV is untreated, they're much more likely to develop TB disease. In 2022, 8 cases of TB had HIV, and that was 4.5% of cases, and that's exclusive of New York City. In 2023, 6 cases, 2.9% cases of TB with HIV had the comorbidity of HIV. Sorry, getting tongue-tied, and that's exclusive of New York City. A person with diabetes and untreated latent tuberculosis infection is more likely to develop TB disease than someone without diabetes. In 2022, there were 43 cases that had TB at diagnosis, and that's 24.2%. In 2023, there were 53 cases, that was 25.2% of cases that had diabetes at diagnosis, and this is exclusive of New York City. The World Health Organization in 2019 found that over 15% of people with TB were estimated to have diabetes globally, compared with the 9.3% among the general adult population. Next slide, please. I'm just going to go very quickly over this slide. Most of you know what TB testing is available. There's the interferon gamma release assay or the blood test. There are two that are approved in the United States, approved by the FDA, the QuantiFERON Gold and the T-Spot. And of course, the gold standard is a tuberculin skin test, also known as a PPD. There are two solutions that are available, Aplosol and Tubersol. Next slide, please. The recommendation for types of tests in adults, the IGRAs are generally preferred, though the tuberculin skin test is acceptable. And the test selection may depend on availability, logistics, and resources. And IGRAs are strongly preferred in individuals who've received BCG or individuals who you do not think are likely to return for the interpretation of the skin test. Next slide, please. In children younger than 2 years of age, a TST is preferred, but an IGRA is acceptable and preferred in some instances. And basically, it's provider decision based on the situation with the child. And again, here, IGRAs are preferred for children 2 years of age or older, those who've received BCG, and any children of any age who are unlikely to return for the TST reading. Next slide, please. This is a chart comparing the IGRA to the TST. I'm not going to go through the whole thing and read it, but the points I want to make are the IGRA is more specific. IGRA is a blood test versus intradermal. There's less. The IGRA is basically 1 or 2 visits. The TST can be more visits, which some patients find difficult. And there's a fixed criteria as far as the interpretation with the IGRA, where the TST is a risk stratified criteria. And it's a subjective, the reading is subjective based on the person's experience. The IGRA is unaffected by BCG in most non-tuberculous mycobacteria, where the TST can cross-react with BCG and non-tuberculous mycobacteria. Next slide, please. Again, IGRA is available in the United States. This basically shows how each one is reported out. The QuantiFERON Gold is reported out as positive, negative, or indeterminate. Any report as indeterminate, you may want to repeat. It may be due to patient immunosuppression or a lab error or a lab performing the test. The T-spot is reported out as positive, negative, invalid, or borderline. The borderline is the one I want to point out here. The quantitative values, these are quantitative values that are near but not reaching the threshold for positivity. And the result interpretation will depend on the patient risk factor. So this is where you have to put some thought into other points or risk factors that the patient may have that could make a difference in the diagnosis. And I would encourage you, if you have a question, please reach out to the TB experts if this is happening, or if you have a patient in this situation. Next slide, please. If you have a patient who does test positive for TB, you need to rule out active TB right away, and that is done with the chest X-ray. At least it can help rule out pulmonary tuberculosis, and this is done right away because you want to make sure that the patient doesn't share TB if they are positive and they have some cavitation or something on their X-ray where they are infectious. You want to take a detailed medical history, a symptom review, do a focused physical exam, checking for lumps and bumps. As we know, TB can be in other areas of the body. You may want to order other studies based on the history or physical, and you may want to take microbiological tests if indicated. Next slide, please. So before we get into some of the treatment regimens, I just wanted to bring up some of the drug abbreviations that are out there. There are drug abbreviations, there are international drug abbreviations, and there are abbreviations that are used more frequently here in the United States and by the CDC. This may not be a complete list, but I just wanted to bring it to your attention because it is always good to, I've had physicians not know basically what the letters mean. So isoniazid can be written as H or INH, rifampin R, RIF, rifapentine, RPT, and then a capital R, and then a small PT, so it goes on. And then you'll see the treatment regimens that isoniazid, rifapentine once a week can be written as 3HP or 4R, 6H, and 9H for isoniazid. So this is just kind of just to make you aware. And certainly if you do have any questions, you can always, again, reach out and ask. But it can get a little bit confusing if you're not necessarily in tuberculosis and talking about tuberculosis and tuberculosis treatment all the time. Next slide, please. So latent tuberculosis treatment, infection treatment, there are short course treatments that are available and are preferred now. They're safe, they're effective, and they definitely have much higher completion rates. The shorter rifamycin-based treatment generally has a lower hepatotoxicity. The isoniazid or INH is still an option, and that's 6 or 9 months of INH, and it can be an option for people who can't tolerate the rifamycins. If treating a contact to a drug-resistant TB case, it's always important to choose the regimen based on the drug susceptibility of the known case. And certainly if you have a contact that you need to treat, you want to reach out to the local health department who is managing their care and consult with a TB expert. Next slide, please. These are the latent TB infection treatment regimens. The first one is isoniazid plus rifapentine. That's once a week for 3 months. That's written as 3HP. And it's appropriate for individuals 2 years of age to adult, and it's weight-based dosing. Rifampin, 600 milligrams daily for 4 months is 4R. The 600 milligrams is a pretty standard dose for an average size adult. However, it can be weight-based dosing for infants and children or adults who are very slight. And it is appropriate for adults, adolescents, infants, and children. Isoniazid, 300 milligrams. The 300 milligrams is, again, a very standard dose for whatever normal adult, but it can be weight-based dosing for adults who are light, very slight, or for infants and children. And the isoniazid can be ordered for 6 or 9 months, and it's written as 6H or 9H. And I might repeat myself, but it's weight-based dosing for infants and children. And isoniazid 300 milligrams plus rifampin 600 milligrams daily for 3 months, 3HR, appropriate for adults, infants, children, and adolescents. And it's weight-based dosing for infants and children. I find that many providers, this isn't used quite as often. I'm guessing because providers, the increase in potential for hepatotoxicity, and you're just adding 1 more month with the rifampin as a preventative treatment. Next slide, please. So now we want to introduce the Latent Tuberculosis Infection Toolkit. It's a practical tool. It provides easily accessible guidance and information. It hopefully will promote the latent tuberculosis infection awareness among community providers. And we hope it will empower providers to confidently treat patients for latent TB infection. And it aligns with the efforts of the Centers for Disease Control and Prevention in Division of Tuberculosis Elimination in moving toward tuberculosis elimination in the United States. Next slide, please. And now we have our first poll. There are 3 questions. Carly's going to pull this up for us. And we'll give you a couple minutes to answer these questions. And here they are. It takes a minute to get them. Okay. And here they're. We'll give you a few minutes. We really appreciate your participation. Okay. So after a couple minutes, we'll take a look at the results. Okay, Carly, has it been a couple minutes?
Yes, sure. We have about 63 votes. So I don't know if we want to wait a little bit longer.
Okay, sounds good. Thank you. Oh, I see it there. Yep.
I also just wanted to add, if you have a question and you put it in the chat, please put it to all panelists so that we can all see the questions that are coming in.
Okay, I think we're kind of hanging on 67 here as a response number. Oh. Okay, let's see the results at this point. Carly, can you pull up the results?
Yes, the first question should be showing. I don't know if you can see it.
Okay, let me see if I can see it. I am not seeing it. So if you see it, you can just read out the results if you want.
So the first question, do you currently conduct TB risk assessments on your patients? 49 said yes, 14 said no, and 6 said sometimes.
Okay.
And in the past 6 months, how many patients have you tested for TB? 13 said none, 15 said 1 to 5, 11 said 6 to 10, 2 said 11 to 15, and 28 said greater than 15. And the final question was, in the past 6 months, how many patients with LTBI have you treated? 27 said none, 20 said 1 to 5, 6 said 6 to 10, 2 said 11 to 15, and 14 said greater than 15.
Okay, great. Thank you, Carly. All right, so we can move on. The next slide. Okay, so I'm going to hand you over to Anthony Maloney, and he will describe the toolkit to you. Thank you very much.
Good morning, everyone. My name is Anthony Maloney. As we previously mentioned, the LTBI toolkit was my project I worked on, the designing and creation of it. So right now I'm going to go over the next few slides, what resources are in the toolkit, how you can access it online, how to navigate it, and then I'm going to show you, I'm going to pull up the toolkit and actually show you what's in it and kind of like a brief kind of overview of it. So the first slide I will go over is what resources are in the toolkit. So there is resources on screening your patients. There is next resources on tuberculosis testing. Next, there's 2 regimen tables on treating your patients that I will pull up in very soon when we go over the toolkit. There will be information on clinical monitoring. Next. There will be educational resources for your patients in the toolkit. The last thing I have on here for resources are the ICD-10 codes. Next slide. So when locating the toolkit, you will go to our website, and on our website, you will see a purple box below information for healthcare providers. And the box states Latent Tuberculosis Infection Toolkit. You click on the box, and then you'll be taken to the toolkit. We also have a link in this slide that will take you to our website where you could access the toolkit. Next slide. So flowchart overview. So one of the first pages of the toolkit is the LTBI flowchart. This flowchart is a progression of questions for when treating your patient. Providers can quickly find answers to the questions by following this flowchart. You don't necessarily have to follow it. It's kind of just a guide for the toolkit just to navigate it. You could start out if you see a topic that you wish to look into, you could just click on it, and I will show you this in a minute when I demonstrate the toolkit. The questions follow progression and include hyperlinks. Each of the purple boxes is a link to a topic, and you click on it and you'll be provided more information on this topic. And on each page, when you click the purple boxes, there are additional links with subtopics at the bottom of each page that you will see if you were looking for more information. And at the bottom of each page, when you click on a purple box, you will be able to return to this flowchart as a guide kind of to this whole toolkit. And now I will show you the toolkit. Is everybody able to see this?
I can see it.
Yes.
Okay, great. So this is our website, the New York State Department of Health Tuberculosis website. As I mentioned, right below information for healthcare providers, there is a purple box labeled Latent Tuberculosis Infection Toolkit. You will click on this box, and it will take you to the toolkit. So before I go into the toolkit, I actually want to mention a few things. First of all, the CDC has recently updated their website. So some of the links to the CDC aren't working. We are working on replacing them. When we fully replace all them, you could go on the cover page and we'll have an updated version with the most recent date that it was updated. So we just want you to look out for that. The second thing that we wanted to bring up was browsers. When you go on our website and access the toolkit, some browsers, some of the hyperlinks do not work in the toolkit. So specifically for Google Chrome and Microsoft Edge, what we encourage you to do is download the PDF version of the toolkit to your computer, and then you'll be able to navigate the toolkit. And it'll make more sense when I show you the flowchart and how you navigate it. But yes, so now we will begin and we will go to the flowchart. Zoom in a little more. So this is the flowchart. As I mentioned, it has all different topics related to treating your patients. So first we'll go to, for demonstrating it, if you were to click the purple box here, should this patient be tested for TB infection? Click it, and it'll give you information on the screening process. As we mentioned, we want this to be really easy for medical providers to find information. So we have a lot of titles that are bolded. We have bullet points for information, just quick, easy ways to access information and find the question you are looking for. I had also talked about in the PowerPoint slides, there are subtopics on the bottom of each page. The first one that we could look at on this page is groups at risk for developing TB. Click on this hyperlink. It takes you to a page on groups at risk of developing TB. We have charts that kind of make it easier too with the bullet points, so you're able to kind of compare and find the question you are looking for. At the bottom of each page too, you can return to the previous page. So should this patient be tested for TB infection, you can click on it, return to the previous page if you want to go back. As you go down on the bottom of each page, there is a arrow that will return you to the LTBI flowchart that is on the bottom of each page. So if you were to get lost or unable to, want to go back to the main flowchart, you could just click this and it takes you right back to the flowchart. One other thing I wanted to show was the treatment regimen tables, the LTBI treatment regimen tables. We have a hyperlink right in here for it. Click. It will give you information on treatment regimens, and there are links and stuff on the bottom of usually each page for more information. We're here, it's FDA drug shortage information, a link to the CDC. And then we can see also the regimen charts. So right now I'm going to click on the infant, child, or adolescent treatment regimen chart. And here it is. So all the information is on this page. Go down. We could return right back to LTBI treatment regimens. One of the hyperlinks on the page, click it, you go back, and then we can see the adult treatment regimen chart as well. Same thing, just for adults, go down. And then I want to return, I click that purple arrow again to return to the LTBI flowchart. And then we are back to the main flowchart page. And again, there are all different varieties of topics on this. If you go to the bottom, you can see the ICD-10 codes. Click on that, information on that. Go down, again, return to the flowchart. We have patient educational resources. See that again, information, hyperlinks all on here. Down, return to the flowchart again. Treatment completion information. And then finally, there are references to what is cited in this toolkit. If you're looking for more information, all the references are available. And we'll return to the LTBI flowchart. Yeah, that is a basic kind of navigation, kind of overview of how to go through the flowchart. Thank you all so much. And now I'll pass the presentation back up to Melanie.
Thank you so much, Anthony. That was great. And we'll move on to the next slide, please. Okay, this last poll. How likely is it that you will use an electronic toolkit and the resources within? We'll give you a few minutes to answer this, and then we have just a couple more slides before we can get into the Q&A session. Okay, Carly, I think we're ready to see what the answer is here.
So 55 people said it's likely that they'd use the toolkit. 18 said somewhat likely. 7 said neutral, and 0 said somewhat unlikely, 0 said unlikely.
Okay, thank you so much. And thank you everyone for participating. That's really helpful for us in developing future educational tools. Okay, next slide, please. All right, these are some really excellent resources. I'm going to just let you read this, but the second one here is the testing and treatment of latent tuberculosis infection in the United States. And I just want to point out, they recently came out with the 3rd edition. It's been updated. So this link will take you to the updated version. And also the drug shortages link, if you start someone, if you're thinking about starting your patient on latent tuberculosis infection, it's always good to check here because we have had shortages over the last couple years. It's been sporadic. It's not constant, but it's always good to check to make sure that you can get the complete regimen ordered. The BCG World Atlas will give you information on which countries give BCG and what vaccine it is. And the World Health Organization tuberculosis profiles can give you information on the countries that the number of cases, number of MDR cases in different countries. Next slide, please. And I want to introduce the entire New York State Bureau of Tuberculosis Control. You've already met Delia Easton, who is our Bureau Director. Dr. Hassengate is our Medical Director. Cheryl Kearns is our Data Unit Director, TB Program Manager. Myself, I'm the Public Health Program Nurse. Melanie Bavrick is the Public Health Field Representative Coordinator. Anthony Maloney is a Health Program Coordinator, and he has recently taken another position. Congratulations, Anthony. And Carly Marone is a research scientist with the Refugee Health Program, and she has kindly helped us with the logistics of this webinar. So now we can move on to the Q&A, and I'll let you take over here.